Okay, we're going to get started today. First of all, I'd like to welcome everybody to today's presentation. My name is Bill Padjane. I'm the Executive Director for the American Parkinson's Disease Association, Massachusetts chapter. Welcome to today's presentation. The APDA has been operating for decades and offers programs and services to the PD community in Massachusetts and surrounding states. We've received a very large response for today's presentation. There has been tremendous progress in the understanding and treating Parkinson's disease. PD is highly individualized from person to person. Not all that is discussed today is relevant to everyone. The healthcare team must be familiar with signs and symptoms, treatment strategies, and how PD impacts the individual patient. Treating PD well requires a team approach. Today, we are providing information and is not intended as medical advice. Thank you. Next slide, please.
Honey, it's not advancing. Sorry.
Yeah. We will be taking questions at the end of the program. Please feel free to type your questions into the Zoom Q&A box. We have a few questions that have been prepared before today's presentation that we'll start with, and we'll try to answer as many questions at the very end as possible, live. And so we won't be taking any questions during the presentation, just at the very end. So the Q&A button is at the very bottom on the bottom panel and Q&A. Thank you. So next slide, please. I'd like to introduce today's speaker. Linda Ng, MD, completed her Bachelor's of Arts degree in molecular and cell biology with honors at the University of Berkeley. She attended Tufts University School of Medicine. She completed her general surgery training at Beth Israel Deaconess Medical Center before completing a urology residency at Leahy Clinic Medical Center. Dr. Ng continued her postgraduate training at the University of Michigan in Ann Arbor as a fellow in female urology, neurourology, and reconstructive surgery. Dr. Ng joined BUMC in 2005 as an assistant professor of urology, where her major clinical interests include male and female incontinence, pelvic floor dysfunction, and reconstructive urology. Dr. Ng's area of clinical research will evolve around various aspects of adult voiding dysfunction. Dr. Ng is the Urology Residency Program Director at BUMC. And so I'd like to welcome Dr. Ng to today's important presentation, Understanding Bladder Issues in Parkinson's. Thank you, Dr. Ng.
Thank you, Bill, Rosemary, and Kathy for this opportunity to give this presentation. I have nothing to disclose. At the end of this presentation, I hope all of you will have a better understanding of how the bladder is affected in Parkinson's disease. In other words, how does Parkinson's disease lead to development of a neurogenic bladder? I will also discuss the common presenting urinary symptoms that bring patients to my office. I will discuss the workup that I recommend in my office. And then I will go over some of the treatment plans that we have available for these urinary symptoms. Before I can discuss what the pathophysiology is of a neurogenic bladder, I think it's important that we review what normal bladder function is. I find the bladder to be an extremely fascinating organ, probably why I'm a urologist today. The bladder has two major functions. One is to provide storage, and the other is for voiding. So in a normal bladder, the capacity is usually around 300 to 500 cc's, which roughly translates to about 1.5 to 2 cups. This is how much the bladder should be able to store before a nerve signal is sent to the brain, triggering the need to urinate. An overactive bladder can develop when these nerve signals are sent prematurely to the brain before capacity is reached. And I will discuss this further in another slide. The bladder should also be compliant. That means it should be elastic, and no matter how much volume changes, the pressure in the bladder should remain low. In voiding, the bladder contracts once the patient has reached the bathroom or they're ready to void. Once this happens, then without the patient having to think about it, the urinary sphincter should relax to allow the urine to empty out of the bladder. Problems in voiding develop when patients cannot contract their bladders with adequate strength, meaning their bladders are underactive. Problems may also arise when the bladder is starting to contract, but the urinary sphincter does not relax at the same time like it's supposed to. A neurogenic bladder develops in patients who have Parkinson's because of fluctuations in dopamine levels. This can directly affect the bladder muscles themselves, as well as the nerves. Parkinson's disease is also thought to impact the pathway between the bladder and the area of the brain that controls bladder function. What that means is the bladder may send signals to the brain before it's full. So instead of waiting for that 1.5 to 2 cups, the bladder may already be sending signals to the brain that you need to urinate when there's a tablespoon, a 1/3 cup, or a 1/2 cup. And each of these signals is interpreted by the brain as you having to void, which can lead to some of the urinary symptoms I will discuss in the next slide. Also, the bladder should not be contracting until you get a signal from the brain saying you're in the restroom and you're ready to void. Sometimes, because of these aberrant nerve signals, the bladder may start to contract before you are trying to urinate, meaning you may have incontinence. So the common urinary symptoms seen include the storage symptoms I described earlier, otherwise known as overactive bladder or OAB. The symptoms of overactive bladder include urgency or a sudden sense that you need to go and you need to go now. Frequency, which is defined as having to void more than 8 times in a 24-hour period. So normal voiding should be every 2 to 3 hours with normal amounts of drinking. Obviously, if you're taking in a lot more liquid, then a little bit more frequency may be normal. But if you're voiding every 15 minutes, half an hour, or an hour with normal amounts of drinking, that is not normal and considered frequency. Urge incontinence is when you have that sudden urge, but before you can pull the pants down or reach the restroom, the bladder's already contracting on its own, and which leads to incontinence. Nocturia, which is the most common symptom, which occurs in greater than 60% of patients, is the most difficult storage symptom to treat, and I will discuss this further in another slide. Voiding symptoms include urinary hesitancy. That means you have this strong urge to urinate, but when you get there, the stream doesn't initiate right away. This is usually due to that sphincter I mentioned previously not relaxing when the bladder starts to contract. Other voiding symptoms may include a poor stream, straining to urinate, and also a sense of incomplete emptying, meaning you just urinated, but you feel that there's more urine in the bladder. I'm going to spend a little extra time talking about nocturia because this is the most common and annoying symptom for a lot of patients and often the most difficult to treat because unfortunately nocturia is multifactorial, meaning it's not only just a symptom of overactive bladder, but also a symptom of other health conditions that may coexist in our patients with Parkinson's. It is also a symptom of benign prostatic hyperplasia, or BPH. It could also be seen in patients with excessive urine production, which usually coexists with medical conditions such as sleep apnea or diabetes. And then also, unfortunately, patients may have to get up to urinate more, not because of their bladders, but because they have sleeping disturbances caused by the Parkinson's itself. Parkinson's is known to upset circadian rhythms and cause decreases in levels of melatonin. This may make patients more hyper alert at nighttime, meaning their sleep is not as deep, and therefore they're more aware of their bladders being full and them needing to urinate. For these reasons, nocturia is not only the most common, but most difficult symptom to treat. I know my talk is supposed to be about bladder issues, but I just wanted to bring some attention to other GU issues such as sexual dysfunction. This is also a problem in some of our patients with Parkinson's because of dysfunction of the hypothalamus. This can result in decreases in libido or interest in sex. It can also lead to erectile dysfunction. When patients come to my office, I always encourage them to have their partners present with them so that they can bring up these issues. There are multiple treatment plans for sexual dysfunction. Patients can be treated with phosphodiesterase inhibitors such as Viagra, Levitra, or Cialis. If they have heart situations or conditions in which these drugs cannot be given safely, then there are other methods for treatment of sexual dysfunction that can be offered, such as injection therapy and even surgical treatment. And it's important to bring this up when discussing your bladder issues with your urologist so that they can refer you to their partners who may have special interests or expertise in managing sexual dysfunction. So why do we bring up bladder issues at all? Because we know these bladder issues and some of these sexual issues have a great impact on the quality of life of our patients. It can lead to physical impact. Patients may limit or stop some of their physical activities. It can be associated with guilt, loss of self-esteem. Patients may fear that they're a burden to their caretakers. Lack of bladder control can lead to them feeling that they emit a urine odor. That may lead to reduction in social times, and they may limit their ability to socialize with their friends. They may feel like their lives revolve around being close to a bathroom. It can lead to extra requirements for specialized underwear, bedding, which is not only costly, but may be embarrassing for some of our patients. And it could lead to occupational impact. Patients may feel that they have to miss work and decrease their productivity because of these urinary issues. And then lastly, sexual issues can lead to avoidance of sexual contact and intimacy. So what should patients expect when they visit their urologist? I often take a general history, do a physical exam. I may obtain a urinalysis to look for things like blood in the urine that may prompt me to recommend other studies. I often do a post-void residual, which means that after you urinate in the restroom, I will have my nurse come into the room and we will scan your bladder with a special ultrasound. A post-void residual tells me how much urine is left in your bladder after you just voided. I may have patients do a voiding diary if I feel some of their voiding symptoms is due to excessive drinking. I will have them record for a 3-day period of what they take in terms of ounces and what type of fluid that they're taking in, because certain fluids may be known bladder irritants. For my male patients, if I'm suspecting benign prostatic hyperplasia, I may do an ultrasound sizing of their prostate in the office. If blood in the urine is seen, or there's another reason that I'm worried about, little growths or tumors in the bladder, I may also obtain a cystoscopy. And lastly, I may offer urodynamic testing, which is a special procedure done in the office that tests storage and voiding problems. So I'm going to go a little bit more into detail about what urodynamic evaluation entails. It's a test that takes approximately 1 hour. A catheter needs to be placed in the urethra. And in my female patients, a second catheter is placed in the vagina, while that second catheter is placed in the rectum of my male patients. There's also a little electrode called an EMG patch that is placed on the bottom or the pelvis. And these three devices help me in evaluating storage and voiding in my patients. The storage phase involves a test called a cystometrogram, which I will show you a picture of it. It really looks just like an EKG. It's an electrical tracing. And in the perfect world, when your bladder is filling, I should see a straight line, because the bladder is just continuing to store urine. It should not be squeezing or sending any signals to the brain until capacity is reached that you need to urinate. In a patient with overactive bladder, we will see some squiggly lines, which I will show on a diagram. During the voiding phase, patients will void into a funnel. This funnel, also known as a uroflow, will allow the cc's per second of urine to be recorded. And also the test will involve a pressure flow study, which measures how much squeeze or pressure that the bladder is able to generate. And then lastly, the EMG patch will allow me to sort of look at what the sphincter is doing. I have included a link here to a YouTube video that I performed with one of my nurses, as some of my patients are curious about how the test is performed. So feel free to look this up on YouTube if you're interested in seeing how an actual test is performed. So as mentioned before, the parameters measured by CMG, we are able to record the volume at which you first feel something in the bladder. And then we test, we make a marking of that. We also mark when that desire gets stronger. And then finally, when you reach capacity. And during this portion of the test, we're able to look for detrusor overactivity or involuntary bladder contractions. We are also able to see incontinence if the bladder squeezes during the filling before you volitionally try to void. During the voiding portion, as I mentioned, we're measuring the rate of urine flow over time. It's a good way to test whether your bladder is squeezing hard enough to excrete all the urine or whether it's underactive. In a patient with BPH or benign prostatic hyperplasia, what we would see on the study is very high pressures. So we know what normal pressure is. If that pressure when you're voiding is less than normal, then you have an underactive bladder. If the pressure is higher than normal, there's more likely a source of obstruction. And in our male patients, that source of obstruction is usually the prostate. And then the EMG patch measures where the sphincter relaxes appropriately when the bladder starts to squeeze, or whether it's slow. And in our Parkinson's patients, the sphincter usually does not respond right away, creating that sense of hesitancy. And this is a typical urodynamic test that's done in my office. This is a patient with Parkinson's. And as you could see where the down arrows are, that green line is the pressure in the bladder. It should have been a flat line, but as you could see in this picture, there's little blips where all those little red arrows are. So at 100 cc's, which you could see volume on the bottom, 123 and 165, meaning before the bladder reached normal capacity of 300 to 400, this person's bladder was already sending multiple signals to the brain that they had to urinate. This would present as urgency or frequency. This patient did not have urge incontinence, but you would also see that on this test. The circle identifies sphincter bradykinesia. That means when the patient's bladder was starting to squeeze, it took a little longer for the sphincter to relax before the urine came out. And you could see in the flow line that is sort of a little jagged line, which means that this person does not have a very strong stream. So once we made this evaluation and has determined that a patient has overactive bladder, then what do we do about it? I often recommend decreased fluid intake, especially at night. Our recommendations are 64 ounces of fluid per day. And that could, I prefer patients drink more water, but that can include other fluids as well. I also recommend timed voiding. That means, using a clock to tell you when to void instead of relying on your bladder to tell you when you need to go to the bathroom. And usually we start patients at about an hour and a half to 2 hours, and then try to, increase that by 15-minute intervals if we can. Bladder retraining can happen on your own or with the help of a physical therapist. And I also advise patients to avoid bladder irritants in their diet, such as caffeine, alcohol, acidic foods, carbonated beverages, which include seltzer water and other bladder irritants. So what do I offer when the behavioral alone does not help alleviate the symptoms? I often at this point recommend some bladder medications. So the most commonly used drugs for overactive bladder are anticholinergic drugs with antimuscarinic activity. Currently, there are 8 anticholinergic drugs available on the market. I've counted oxybutynin 3 times because that particular drug comes in an oral formulary, a transdermal patch, and also a gel. The other medications are danafenicin, fisteridine, sulfenicin, totiradine, and trospium. I've highlighted trospium in red because this is the only anticholinergic that is a larger molecule than the others and doesn't cross the blood-brain barrier. There are now studies showing that the other 7 drugs with long-term use can lead to memory impairment, which is already a concern in my patients with Parkinson's. So in my practice, I try to avoid use of 7 of these drugs unless their insurance does not cover the drugs I prefer. The good thing is that beta-3 adrenergic agonists are now available, and these drugs have not been linked to memory issues. So what are the side effects of some of these anticholinergics? First of all, they're contraindicated in patients with urinary retention, gastric retention, or uncontrolled narrow angle glaucoma. They are safe in patients who do not have narrow angle glaucoma or whose glaucoma is well controlled. Dry mouth was the most frequently reported adverse event. Others include headaches, constipation, nausea, and dry eyes. And as I mentioned earlier, recent studies now suggest that long-term use can cause cognitive decline and dementia. So my preference, other than the trospium, is to avoid anticholinergics if possible. Beta-3 agonists have no anticholinergic side effects, which means they do not cause the dryness of the eyes and the mouth and the constipation, which can be bothersome for some of my patients. Beta-3 agonists work by increasing bladder capacity by relaxing the muscles in the bladder. There are currently 2 available beta-3 agonists. The first one that came out a while ago is called mirabegron or Migbetrix. This has hypertension as a potential side effect. So I do warn my patients that, we need to monitor their blood pressure in case hypertension is a problem for them. Mirabegron or Migbetrix comes in 2 dosages, 25 milligrams and 50. So this allows me to titrate this medication as needed. So I usually will start, depending on the patient, with 25 milligrams. And if that's effective, but they need a little bit more drug, I will increase it to 50 milligrams in about 2 weeks' time. Most of the time, these drugs work by 2 months, and that's when I have patients follow up with me. If you're given a bladder drug and it's not effective in 2 months, it's probably not going to be an effective drug for you. The other drug that recently came out, just about 8 months ago, is Gemtesa, which is not yet available in a generic format. Its claim that it's better than Migbetrix is that it has no significant changes in blood pressure. And I have used Gemtesa in some of my patients who feel that the Migbetrix, which worked initially very well for them, is starting to wear off. Gemtesa does only come in a 75 milligram dosing. And with any of these drugs, after a while, your bladder potentially may get used to them, and we may need to cycle between different brands to get that, new exposure of the bladder to these drugs again. So, even if a drug is working well, you have to understand at some point it may stop working as well, either because your bladder's gotten used to the drug or the condition of the bladder has worsened, meaning the neurogenic bladder has worsened because the Parkinson's may have worsened. So what are the alternative managements for overactive bladder when behavioral modification and medical management with oral agents are not effective enough? We can send our patients for biofeedback or pelvic floor physical therapy. In Boston, I have a list of all the available pelvic floor physical therapists, and these are specially trained physical therapists who do extra training in pelvic floor. Not any, physical therapist will do. Also, some of my patients have had deep brain stimulation for their Parkinson's, which indirectly has helped them with some of their overactive bladder symptoms. I also offer botulinum toxin injections to the bladder, or Botox, to my patients when they are refractory to the oral agents. Botox is significantly stronger than any of the oral medications and therefore has some side effects that I will discuss on the Botox slide, but it is much stronger for patients who find that the bladder drugs are not strong enough for them. If my patients have BPH or benign prostatic hypertrophy, I will also send them for treatment of their BPH with one of my BPH expert partners. I've also mentioned on this slide 2 forms of neuromodulation, which are still being studied. There are some urologists who do perform neuromodulation on their Parkinson's patients. I personally do not. I'm waiting for more data, but for patients who have very refractory overactive bladder and who are willing to try anything, these are available. With percutaneous tibial nerve stimulation, a small fine needle is inserted near the ankle area and the tibial nerve is stimulated. This usually requires about 12 one-hour sessions. And then with the sacral neuromodulation, a wire is inserted in the spine and the S3 space. And I have a slide on that as well. So this is what Botox looks like. So during a Botox procedure, some patients may opt to have this in my office, but often I encourage patients to have this done under light sedation in the ambulatory center because it's quite, can be quite uncomfortable for some patients. It involves placing a small camera up the urethra into the bladder, and then a special needle is inserted through the camera, and then injections are done all over the bladder. When Botox first came out, most people did it in rows. Most of us now kind of just spread it all out. It takes about 10 minutes. The main risk of having a Botox injection include infection, temporary blood in the urine, and the main side effect is actually retention. So the main purpose of Botox is to stop some of these extra contractions. In doing so, it may relax the bladder too much and turn the overactive bladder into the underactive bladder. And the risk of retention or having difficulty voiding requiring a catheter is quoted in the literature about 8 to 10%. For this reason, in my patients with Parkinson's, I usually start with a lower dose of 100 units rather than the FDA recommended dosage of 200 units for the neurogenic bladder. So sacral neuromodulation really is a bladder pacemaker. It's very similar technology to the cardiac pacemaker, and is actually made by the same company. It's an implantable device, and usually before the final device is placed, there's a test period where a test wire is placed in the sacral foramen in the spine for 1 to 2 weeks. And then the patients record for a 1 to 2 week period how many less urgency, frequency, and urge incontinence episodes they're having. If the OAB symptoms decrease by at least 50% on their voiding diary, then they go in for a small surgical procedure where the pulse generator is implanted in their buttocks. So what happens when behavioral, medical, and some of these alternative therapies are not effective? At that point, I usually recommend that we try to help patients deal with their incontinence instead. And I usually recommend pads or diapers for our male patients to help them deal with, incontinence at night, and maybe using the bathroom frequently at night, which is a risk for falls. We offer our patients condom catheters, which is a condom attached to tubing that is then connected to a leg bag that they can use as an alternative to pads or diapers. So, what do we offer for voiding dysfunction? Up until this point, we have mainly been talking about treatment of storage symptoms or overactive bladder. So for our patients who have urinary hesitancy, meaning they really have to void, they get to the restroom and then the urine doesn't come out easily, we usually offer alpha blockers in the form of tamsulosin, of alfuzosin. These are smooth muscle relaxers that help the sphincteric muscles relax. It also works on the prostate, but it is not a prostate drug. So it is safe to give these drugs to our female patients as well. The main risk of taking alpha blockers is a drop in the blood pressure, which may lead to dizziness. In some of our patients with Parkinson's, having low blood pressures is a problem. So we do want that monitored very carefully. And we also recommend that these drugs be taken at night so that if there's a small drop in blood pressure or some dizziness, it's happening when the patient is hopefully asleep. We can also offer pelvic floor physical therapy, or PFPT, to teach patients how to try to relax those sphincters without medication if they cannot tolerate the side effects. For obstructed voiding symptoms such as BPH, we would offer patients surgical management. And now we have multiple surgical modalities for management of BPH, ranging from like metal rubber bands to laser therapy to vaporization. In the past, we only had transurethral resection of the prostate, which resulted in more risk and blood loss, but now we have more minimally invasive techniques that can be offered, especially to our patients with Parkinson's. However, if the bladder is underactive, which means that it cannot contract or squeeze hard enough to empty the urine, unfortunately, we have less medicine or therapy to help with this problem. So for our patients whose bladders just have really stopped working or aren't working enough or well enough to push the urine out, we at this point recommend intermittent catheterization, which means the patient would have to use a catheter every 4 to 6 hours to empty their bladders themselves. This is offered only if they have hand-eye coordination or manual dexterity that allows them to do so. For our other patients who really can't empty the urine out of their bladder and start getting symptoms such as urinary tract infections, which result when you leave your old urine in the bladder too long that can't be, voided out, we will offer a suprapubic catheter, which is a technique in which you drill a small hole in the bladder through the skin. And if you think of a clock, a suprapubic catheter is placed at the 12 o'clock position, while an indwelling Foley goes through the urethra and is placed at the 6 o'clock position. And these surgical techniques are mainly offered for patients who have underactive bladders, who can't empty their bladders, but who are symptomatic. For patients who are not having symptoms of UTIs or feeling that they're really not getting the urine out, we just observe our patients. So in conclusion, lower urinary tract symptoms or bladder issues can negatively impact the quality of life for our patients with Parkinson's. Sexual dysfunction is often also present and can further impact the quality of life. So I would recommend a referral for further urologic evaluation to see if in your particular situation, options for management can be offered. Treatment options currently include behavioral modification, pelvic floor physical therapy, medical management, and also surgical management, depending on the situation. Thank you.
Thank you so much, Dr. Ng. We've got a few questions. Wonderful presentation. And thank you for your complete overview of today's topic. So I'll start with the questions.
Okay.
The first question I have is, I mentioned my night urination issues to my neurologist, who did not address. How would I make an appointment with a urologist that understands Parkinson's?
So depending on your insurance, some insurances allow patients to self-refer, and they can call the urologist's office directly and request an appointment. Otherwise, they can ask their neurologist or primary care physician for a referral. There are those of us who specialize in the field of neurourology, and these are urologists who have further fellowship training in FMPRS, which stands for Female Pelvic Medicine, Neurourology, and Reconstructive Urology. So they could look up specific urologists who have those credentials, who have special training or interest specifically in treating the neurogenic bladder.
Thank you. Next question is, why are urinary tract infections common in Parkinson's?
As mentioned in one of my slides, when patients develop an underactive bladder, meaning their bladders cannot adequately squeeze to empty their bladders out, leaving old urine in the bladder can lead bacteria to grow, and that in turn can lead to a urinary tract infections. So if urinary tract infections are common for patients, I will often, do the urodynamic testing to see how well they're emptying their bladders, and hopefully that there's something we can offer the patient, especially if an enlarged prostate is contributing to that.
Good. Next question I have is, how long should you try a new medication for bladder before you know it's working or not working?
I usually have my patients trial medications for about 2 months. I feel that at 2 months' time, if you've not had any response or improvement, that you're unlikely to have a response. And at that time, I will usually switch the drug or try another modality of treatment.
Thank you. People with PD have constipation issues. Can that cause problems with OAB?
Yes, the answer is yes, because the intestines and including the small intestine, the colon, sit directly on the bladder. And so when you're frequently constipated, that could exert extrinsic or external pressure on the bladder itself, which can also cause the sensory nerves in the bladder to send premature messages to the brain that you need to urinate. So often I will recommend to my patients who have a lot of constipation and other GI issues that they concurrently see a GI specialist to help, maximize their bowel function.
That's great. Thank you. How does an enlarged prostate impact PD bladder issues?
Well, so the prostate sits right at the base of the bladder. So if you have let's say the bladder is already weakened from the Parkinson's, there's decreased contractility, and you have something blocking it in addition to the decreased squeezing, that patient's going to have more difficulty emptying their bladder because they have two sources. One's a weak bladder, the other is an obstructed source. And so there's not much more we can do to make the bladder stronger, but we can unobstruct that patient by offering them a procedure to relieve the blockage from the prostate. Plus, as I mentioned, benign prostatic hyperplasia, or BPH, is also a source for overactive bladder. Let's say your bladder is not weak at all. Let's say you have normal contractility. All that extra squeezing that the bladder has to do to push the urine out past the obstructing prostate will essentially drive the bladder crazy, causing it to be more overactive. So, you have a risk of overactive bladder from the Parkinson's itself, and then the enlarged prostate that's causing blockage is worsening that overactive bladder.
Thank you. Next question is, what is the natural course of OAB if left untreated?
It's all about quality of life with overactive bladder. In general, it tends to worsen with time as the nerves worsen. So some of my patients, find that their overactive bladder symptoms are not bothersome, and they don't want treatment at the particular time that they see me. They just want to hear more about it. And then they will often come back when they find that the symptoms of their overactive bladder become more troublesome. There comes a point where you're like, okay, I'm willing to undergo the risk of some of these medications and other treatments because I'm very bothered. But that when you become very bothered, I feel is very different for every individual.
Thank you. Next question is, how does a daily dose of HCTZ affect these treatments?
Well, that's a diuretic. So a diuretic will cause your kidneys to produce more urine. So if getting up at night frequently to urinate is a problem, I often recommend that the patients not take their hydrochlorothiazide in the evening hours, because then as the diuretic works, you're going to be up all night voiding. So it's best taken in the morning. But unfortunately, it's doing its job of producing more urine. So the frequency may not be from overactive bladder. It may just be that you're producing more urine and therefore your bladder's filling up more quickly.
Good, thank you. Next question is translucinin taken just before bedtime a good option for frequent urination?
It can be. Tamsulosin, or otherwise known as Flomax, is a muscle relaxant. So if some of the symptoms are due to not emptying the bladder out, in entirety because of the slow sphincter, then it would work. If you don't have any sphincteric issues or BPH, then it's less effective as a drug for the bladder alone. It has no properties. It doesn't work on the bladder at all. So if your frequency is due from overactive bladder, then you also need a bladder medication.
Thank you. How long does Botox last and how often do you need to have it done?
Botox for the average patient lasts about 6 to 8 months. So my patients who've had good efficacy return every 6 to 8 months to see me. I do have patients who say it lasts 9, 10, 11 months to a year. I have one lady who insists it lasts 2 years for her. So she comes every 2 years. So I won't usually know how long it's going to last and when it's going to wear out till the first injection. People tend to stick to a schedule. So it's, dependent on how well or how long it takes for their body to break down the Botox.
Thank you. I've got a few people raising their hands, and just so that you know, we don't have that option available today. If you have a question, we'll try and get to it. We've got a few more minutes to go. If you have a question, please put it in the Q&A box and we'll try and get to it. We are going to get this up on YouTube. And if you have any additional questions, please reach out to your information referral center or your local chapter. My doctor has recommended Nocturna. Can you explain how this works and how effective it is?
It's that's usually a medication that I leave up to our medical personnel. It's an effective medication for patients who they feel that the nighttime waking up is due to excessive urine production. So it works on a feedback system. The main risk of taking it is it can cause the sodium levels to really plummet. And so the sodium needs to be very carefully monitored. So it's effective medication for patients who wake up at night to urinate, but only due to the nocturnal polyuria, meaning it's thought that they're making more urine at night because of another medical issue.
Thank you. And so one of the other questions we have is there a specific diaper type that you'd recommend or brand?
No, not really. It's kind of like a trial and error for some of my patients. There's not, some of my patients prefer pads. Some of my patients prefer pull-ups. And it's a matter of trying different types available until you find one that you're most comfortable with. I have some of my patients who request that I give them prescriptions. So like the patients to know that, they could always ask their primary care doctor or urologist to see if their insurance will cover these products, because then it may save them a huge cost every month. And often a lot of these medical supply companies will send you different types. And so maybe you could try some, different types until you find one that you're comfortable with. The condom catheters, if that's an interest for our patients, those need to be fitted. They're sized to the individual patient. And if once we size the patient, if they're interested in doing that, then we can have supplies sent to them to their homes.
But I've got just 2 more questions, please. Thank you, Dawn. Does melatonin help? And if you could recommend a dose for that?
Well, the melatonin is usually recommended and prescribed by our neurologist. And I've seen all different dosages used by that. For our patients who really have sleep problems, it's a medicine with low side effects and low risk. So I would recommend that they discuss that with their neurologist and get a prescription.
Thank you. And one last question, and thank you for answering all these questions. Can the condom catheter be used for all-day control?
Can you repeat that, please?
Yes. Can the condom treatment be used for all-day control?
Yes, it may be. So some patients find that it is, it doesn't get pulled off for the whole day, and then they could use it all day long. Depending on how active the patient is, occasionally it may pull off, in which case you may need to reapply another one. So usually our patients request like 2 a day, just in case one falls off. But yes, it could be used from day to night.
Thank you. That's the conclusion of our Q&A section. I just want to remind everybody that we're going to be getting this presentation up on our YouTube page, hopefully within the course of the next 2 weeks. I'll also be sending out the link to everybody who has registered. We won't be able to share the slides. However, we will be, sharing the presentation that includes the slides. And so we've got information referral centers dotted all over the country. I know that there are people here from all over the US. Here in Boston, we have an information referral center at Boston University Medical Campus. The phone number is 617-638-8466, referrals, resources, and any questions you might have. We also do education support, and we have health and wellness programs, not only available in person, but online. If you haven't already, make sure that you reach out to your local chapter. We've got a lot of events planned over the course of the next couple of months, and we'd love for you to participate. This Friday, we have a presentation that the APDA of Massachusetts is presenting on, and it's going to be Dr. Terry Ellis is going to be providing a research update in PD, physical therapy, and rehabilitation. And so that's available on the APDA MA website. We also have our optimism walks coming up here in Massachusetts. Our optimism walk is in Framingham on May 22nd. We'd love for you to participate. You can either register or come. It's going to be a very large community event, and we hope to see you there. I want to thank Dr. Ng for today's wonderful presentation. She did a wonderful job. We got probably the highest amount of participation that we've had with these virtual education sessions. So I want to thank Dr. Ng for doing a great job today, and for everybody coming to today's presentation. We got through the majority of the questions. We got very many. Hopefully we'll be able to answer all the questions moving forward. I want to thank everybody for participating today. And again, thanks Dr. Ng, Kathy Thomas, as well as Rosemary Owen. And hopefully everybody will have a wonderful day. And thanks again. Thank you.
Bye-bye.
I know.